Thanks, Doug, and thanks to all the speakers. I'm going to start off the moderated session with a couple of questions, and then I'm going to open it up to the committee members. First, I actually had a couple of questions for Rick. One is that when you implemented your patient education, your education to the providers, and they changed their prescribing practices, there was still quite a range. So some prescribed 0 to 40, for example. Did you have any information about what would make a provider decide for the same procedure that they would prescribe no opioid versus 40 milligrams? Was there any information you had about that, or could insight?
We did examine look at the providers and try to figure out who were the ones who were still overprescribing, and it turns out that there were 4 prescribers who were mainly responsible for the vast majority of the overprescriptions. 2 of them were fellows who kind of missed the intervention, the educational intervention. They kind of came in and started in August, so we sort of missed educating them. So we did look into that, and that accounted for a good part of it. We didn't have really recalcitrant providers who weren't interested in sticking with the guidelines.
Was there anything that predicted when they thought a patient would not need opioids, or did that just kind of come naturally?
Sure. There were some providers who didn't prescribe any opioids to patients also. So that is true, and it just kind of came naturally, right? So in some situations, yeah.
Okay.
Yeah.
I have a question for Holger and Paul. So I thought both of your presentations were very interesting. In Paul's presentation, some of these concepts of parallel evidence and mechanistic evidence, I think in grade would be kind of considered indirect. Is that correct? And Paul presented a case that those types of evidence could actually increase your certainty, whereas in grade, if something is indirect, that actually decreases your certainty. So I'm wondering if you can just comment on that. Is there a contradiction there, or is there not?
I don't necessarily think that there's a contradiction. I would possibly phrase it a little bit differently. I would say that indirect evidence, mechanistic evidence, and we should define what mechanistic evidence actually is, because that definition is not a very narrow or uniform definition either, may lead you to not rate down for indirectness. So I'm not necessarily thinking that there's a contradiction. So if we take the parachute example, for instance, which is an example that is very frequently used, the issue here is that it's probably not so much the mechanism that has convinced us, because the first animals that volunteered to use a parachute didn't do very well based on the presumed mechanism. But it was actually the repeated observation, in other words, the large effect that made users of parachutes very confident that parachutes worked. So it was not necessarily the math. And then if we think of the physics or the laws of gravity in this particular context, these laws need to be applied. They need to be demonstrated by empirical evidence. And in fact, I would just also there, so Paul Glacieux, who's one of the authors of these papers, is a member of the GRADE working group, and we did discuss biological mechanisms about 10 years ago when these papers came out. And at that time, once again, put it into the indirect evidence category, and felt very much, and that goes back to the issue around homeopathy, that biology or mechanisms often define the type of questions that we are asking. So we shouldn't be asking irrational questions, and that probably to some degree relates to the indirect evidence piece as well. But just to answer your question, I don't think it's necessarily a contradiction. I'd be probably hesitant unless there were large effects observed by mechanistic evidence or indirect evidence to rate up the certainty of evidence, because I wouldn't know what the actual operationalized criterion would be except for that one. Maybe dose effect relations, that could be applicable as well, and that would be a great criterion. Or that, those are probably the two criteria.
Paul, did you want to comment also?
I mean, I don't think that these things are necessarily I don't think that there's necessarily whatever the term you used was, or Roger. I would differ slightly from Holger in saying that I think that it is a large effect and a repeated large effect, because I think that in some cases the difference between the untreated and the treated state is so large that even a single or two uncontrolled observations is probably enough with a mechanism that's plausible. So, but I mean, we agree on a lot of things, but whatever, the first artificial hip that went in that allowed somebody to walk you probably didn't need 100 more before you concluded that that might be a large effect. But in general, I would say Holger and I agree on those things.
Great, thanks. I have a question also. I think this is to all the speakers about, it has to do with the outcomes we're looking at and kind of prioritization of outcomes, as well as kind of stakeholder input. And so many of the outcomes we are looking at have to do with amount of opioids used. There are a lot of more clinical outcomes that we're interested in, as well as other intermediate outcomes that we're interested in, including things like mortality and morbidity, long-term opioid use, substance use disorder, long-term, and pain, function, quality of life. What are your guys' thoughts about what thoughts do you have about how to actually do the prioritization, as well as how to engage stakeholders in this process, including patients? Are there methods that you've used and that we might consider as we think about setting up our frameworks?
With regards to outcomes, I think for us, we looked at quality of life, side effects, but I think mortality was one of our largest, or overdose deaths. And there was decent evidence from high morphine milliequivalents, that the higher you went, the more likely you were to have an overdose. And there were some recent studies that had come out that helped with some thresholds. So I think that was one of the areas that we really focused on, because that was something that was really concrete. We didn't say that you couldn't ever go above that morphine milliequivalent, but we talked about really using guidance and discretion at different levels and when to engage pain management specialists. I think when it comes to input, you can never have enough. You do have to know what to do with it, though, and so at some point you have to set a limit on how many different venues you have and what you're going to do with all of it. When we had 4,372 comments, we did have to read them and try to figure out how to incorporate them. But I think you can look at many different ways to do it. One is through the webinars, which I know National Academy does, to where you can then get input on steps along the way. I think posting things for public comment is really helpful, because it can get a much broader audience than would participate in a webinar. And then I think targeted outreach to different partners or organizations is helpful.
I could very quickly speak to that. 2 points, perhaps, starting with the relevant questions that was also discussed a bit earlier. What we, for instance, did in these 10 fairly large guidelines with the American Society of Hematology just recently was to have a public consultation phase around the most important questions, and the individual panels for 10 guidelines developed a list of questions, sometimes 50, 60 questions, and then we vetted the importance of these questions with outside stakeholders. And there it became very obvious that it's often, we developed a list of criteria that one should consider in rating that importance, that it's not necessarily where there's good evidence, but what really matters in practice. And I think there was a little bit of a debate in the earlier panel, because you want to answer questions that are at the forefront. So working with external stakeholders, and then with regards to the outcome generation, we typically use some multiple approaches for that. So sometimes there's good utility literature. We work with the individual panels which are multidisciplinary panels, as was already described. That includes then, and it may include outside stakeholders, again, these type of groups that we were talking about, always including, I think appropriately, always including patients or people with the condition, as well as possibly without the condition. And then just something that the process can actually become so burdensome or cumbersome that you don't get the work done. And a quick example for that is possibly we've been doing reviews in this antithrombotic area for a very long time, and felt that they informed many guidelines over time. We nevertheless went back and repeated the effort about, for instance, identifying the important outcomes, and we realized that the outcomes were addressed over a long period of time. And in certain circumstances, it's probably not. You probably want to invest your resources in other aspects of the actual guideline development work. So I think that requires a fine balance. So when there are established questions that have been addressed by many guidelines, you probably don't want to spend as much time on selecting the right outcomes. You want to possibly spend that time on addressing an additional question.
Kind of follow up on that, I guess one of the issues could be that, say, patients have a very different priority about the most important outcomes. They may say my pain relief is the most important priority, whereas other stakeholders may say prevention of long-term use and opioid use disorder and other associated outcomes. And how do you balance those competing perspectives?
One more, if that's okay, I'll try to take this one. It's very interesting because I believe that in terms of guideline development methods, we for a long time have made big mistakes in terms of how we try to answer that particular question, and that is that we haven't provided sufficient definitions over the past 20 or 25 years in terms of what we mean by those outcomes, and that a lot of disagreement is actually resulting from not being able to communicate between the guideline development groups, the providers, and the patients or people living with the conditions of what that outcome really is. So what is moderate pain? It was mentioned a bit earlier. I think some of the disagreement actually can be resolved when we are really talking about outcomes that are important for people who make the decision through better definitions of these outcomes. And those are not the definitions that are used in trials typically. These are definitions that are utilized to really, we've called it health outcome descriptors. It's actually very well known in the utility field, or marker states, that we develop before we determine what outcomes are possibly important. So moderate pain, what does moderate pain mean? What are the symptoms? How long does it last? What needs to be done in terms of interventions, or what are the relevant interventions? And we've done that in these ASH guidelines that I just described, and recently in the European Commission breast cancer screening guidelines. And we feel that resolves some of these issues around differences about what matters to people who are affected by the condition. So that is certainly one way, and I truly believe that is very important to address right up front. And see where the disagreement is coming from by just labeling an outcome, pain, constipation, abuse of drugs. That is not sufficient to find agreement, I think.
I would just add to that. I think you can involve patients in the process. So I think whether it's through we had one on our Federal Advisory Committee subgroup, or whether it's through the public input that we got. And I also think it's to be important to emphasize we're not against treating pain, that there's just evidence-based ways that can treat pain that are not opioids. And when you look at long-term opioid treatment, the evidence doesn't show that it's as effective for chronic pain, and that we want to treat the underlying condition. So I think it's working with patients around the messaging and ensure that we do want to treat their pain.
Thanks. And then I just have one more before we open it up to the committee. So, the analytic framework and chain of evidence approach that Doug showed that the task force has used for many years, my understanding is that, GRADE does, allow for this kind of approach. Again, GRADE, that's one of the domains of indirectness is kind of these indirect chains of evidence, and typically, you would think about, do you have to downgrade because it's not direct? And I think the task force is very comfortable, feeling that the evidence is certain by working through those chains of evidence, and this is one of the things we're likely going to have to do here, because we have very little, again, we have very little direct evidence on impact of dosing on clinical outcomes. So I wonder if Doug and Holger, you might be able to just comment on, how using this chain of evidence approach works and how it fits in with grade.
Well, I can take a stab at that first. I'd say, Roger, sometimes we're comfortable and sometimes not. I mean, we sometimes feel like the indirect pathway fails. There's, one of those linkages, those arrows, or the association between intermediate outcomes and final outcomes isn't sufficiently, there isn't sufficient evidence for us to make a recommendation. So it's sort of case by case for us, and we spend a good bit of time. You'll remember the hepatitis C example, where we were, back 5 years ago, looking very, very carefully at whether sustained viral response from drugs really resulted in the health outcomes that we were interested in. We concluded that it did, but that was a lot of discussion.
Thanks, Doug.
Just perhaps very quickly, I think the analytical frameworks, as you already indicated, are extremely helpful for developing the right questions. They help you think about the benefits and the harms that should be considered. Obviously, they also create that information that you need to assess possibly linked evidence. In particular, if you think about diagnosing individuals or people, and then moving to the relevant interventions. So that evidence is not necessarily included in the studies that you identify if you were just to focus on intervention effects. One of the examples that makes that I think very evident is the wrong use of multiple oral vitamins. If we think of beta-carotene use and vitamin E use, there were studies that repeatedly demonstrated that leads to, in most populations, to more harm than benefits, and that evidence can be put out there, but it's a different type of evidence that helps us to then say, how can we make sure that that people stop using, in particular if they're at risk, such as smokers and so on, stop using this type of intervention, and that would be in an analytical framework, in a complete analytical framework, I think, addressed, and those different pieces of evidence. So there's evidence about intervention effects, and then there would be evidence about how you implement those type of interventions, in particular if it's recommendations to stop doing something, how you implement that. This is a different type of evidence, and it can either come under implementation considerations in the grade framework, or it can lower your overall certainty in the evidence if there is a lot of uncertainty that those type of interventions are actually implemented into practice. So there's a few ways of disentangling those linked pieces of evidence.
I actually have one last question. This is for the whole panel, and it's thinking about this topic maybe kind of broadly as a harm reduction kind of area, where the evidence is often actually quite different than we have looking at whether something works or not or should be given for an intervention. And by that I mean that for example, if we think a drug causes a certain side effect, we have that association. We know that association occurs, but oftentimes the interventions we might do to prevent or detect that side effect, we don't actually have direct evidence that doing those things actually improves clinical outcomes. So we don't have direct evidence that monitoring for high potassium in somebody on an ACE inhibitor or checking a chest X-ray before starting a DMARD or whatever, any of those things actually improves clinical outcomes. But in this kind of harm reduction paradigm, I think most people accept that those are reasonable things to do based on the associations we know that occur. And, there's some parallels, I think, here in the acute pain world where we know that opioid use is associated with certain long-term outcomes. And so I guess the question I'm wondering at is there any reason to kind of adapt or modify kind of the way we normally look at interventions and assess them to develop guidelines, because this is a harm reduction paradigm? I mean, the FDA, for example, will withdraw a drug from the market on a basis of a handful of case series, which we would never use to determine the efficacy of a drug. So just kind of a conceptual or philosophical question about how do we approach these things when the interventions we're giving can be associated with really serious harms, and do we just use the traditional evidence frameworks, or is there room to kind of adapt them?
Roger, this is Doug. I apologize. I'm going to have to sign off. But, I would say we haven't done that on the task force. I think it might require some modification, but I think that we probably could get there. But we haven't done that, so take that with a grain of salt.
Great. Thanks, Doug.
I think it reminds me most of the frameworks that we've used. Now, framework, I should be careful with how I use the word framework. The linked evidence that we've used in the context of screening or diagnostic recommendations, where again, that linkage of what we know about, for instance, the diagnostic performance of a test, the subsequent treatments, and then the implementation into practice, that those are all individual pieces of evidence that need to be grouped or put together in some way or another when there is uncertainty. So I think we could very quickly come back to the example that I just described. For instance, in the beta-carotene and vitamin E example, it's impossible to remove vitamins from the market. And therefore, you're offering a recommendation to smokers to not use beta-carotene and vitamin E when the first trials came out in the late 90s had limited effect because people thought that they were doing benefits to themselves. It was impossible. But if FDA, for instance, removes a medication reliably from the market, I'm not talking about opioids specifically here, and this intervention is not available anymore, then that uncertainty is much lower, and you probably don't need to include that necessarily into your into the consideration of uncertainty about whether or not you achieve the effect that possibly has been demonstrated. Effect here meaning the degree of harm. And I think those are the considerations, and therefore probably it's very worthwhile looking at implementation literature in this context. Those are the considerations that a panel should have. Sometimes it's very simple to withdraw an intervention. Sometimes it's really hard, and that contributes to that linked evidence, in my view, at least. And it's one particular piece in the great diagnostic frameworks.
So I'd like to open it up to the committee if they have questions for the panel members or clarifications or other comments. Yes, Eric.
I'm Eric from Stanford. Maybe I can follow up on Roger's point. I think what's challenging in developing a framework is when I think about the kind of evidence we're likely to find. I think direct effects that these guidelines are going to impact some outcomes like mortality, drug abuse. It's going to be very hard to find. I mean, Richard, your study is about 300 people, right? Probably not going to have the power there to detect those things. And so the direct evidence is very hard to find. Now, the indirect evidence, good evidence that these programs are reducing pills that people are filling, right? But then going from pills filled to sort of morbidity, again, that's very tough, right? I mean, I don't really know if those studies are out there. I mean, you could say grossly we know prescriptions have gone down and yet deaths haven't. So if anything, maybe the evidence really isn't there. I don't know. But so certainly that evidence, I don't think, right? I don't think we're going to be able to tie sort of a 50. I mean, again, there's something intuitive that if we reduced opioid prescribing by 50%, that would, result in good things. And sort of, so I think that's sort of the challenge here. And I think sort of many of these papers are operating from kind of, I think, what Roger brought up in terms of harm reduction or equipoise, which is to say that, the studies are finding that people are using fewer pills, and yet it doesn't seem like pain has gone up. And that, probably that's just kind of ex ante. People would say a good thing, even if there's not really evidence to suggest that that's completely true, right? I mean, so I don't know what you think about that, but because I think that's kind of the evidence we're going to have now, and I think that's kind of the evidence you're going to get in the future, right? I mean, the large randomized trial that you would need to find deaths or other things that you're not going to find, I don't think that's going to happen.
I agree with your assessment. I think that it's appropriate opioid prescribing. I think it's the most important thing. So I don't think anyone's talking about ratcheting the number prescribed down so low that people's pain isn't going to be taken care of. I mean, I don't think it's a dichotomy. Sort of, I think you can still take care of patients' pain. So you just by setting the bar appropriately, and so that you can get the benefits of the potential benefits of less opioid overdose deaths from having less prescribed over time.
Could you comment? I think I remember on one of our phone calls you had mentioned that you guys were planning to do some studies with clinical outcomes. Is that correct, or is that have you submitted some proposals or something?
Well, we have a prospective study that we're undergoing right now just to try to prospectively validate our inpatient opioid use study, and we are planning to look at some long-term outcomes. But again, it's going to be a small study, and it's hard to know what exactly that's going to show.
Thank you all for really interesting presentations. I had two questions. Let me start with the second, and if there's time after Kit goes. Thinking about the GRADE and other frameworks for evaluating evidence, one thing I think that we're likely to be interested in is population-level outcomes. And so the outcome may not accrue in the individual who is prescribed or not prescribed, but rather in the community or population level. And so I'm curious to know, in the framework you presented, how that might change the kind of evidence you might weigh. And I'm thinking in particular about ecological studies, which I know are sort of not probably high up on the evidence hierarchy, but maybe the only route to answer population health level outcomes.
Yeah. So that possibly also addresses the previous question a little bit. I think here we cannot make the evidence better than it is, and just because we don't have better evidence, we cannot place higher trust in that evidence as compared to other healthcare questions. And I think we just needs to be acknowledged. But so you can have low certainty in the evidence, as I said before, but high confidence in the process and high certainty that you actually followed a good development guideline, methodology, or whatever that is, and be transparent about it. And I think these two things need to be kept separately. And under those circumstances, in many instances, as you just suggested, in many instances, you would, even on a population level, make what we call conditional or weak recommendations. And under those circumstances, an individualized decision-making process with a patient who may have a certain set of values, if these values can be reliably elicited, a conditional recommendation will be appropriate. And in reality, it's always this way. Recommendations and guidelines are typically for populations. Sometimes we can narrow it down, sometimes we can't. That's what the mandate of a guideline is. The decision-making process becomes more important to be individualized when there are factors that make us less certain, such as lower certainty of the evidence or lots of variability in the values and preferences or self-payment and so on. And the frameworks allow for that and should be able to address that particular issue.
Yeah, just to follow and maybe also ask Deborah to weigh in it's for me the logical sort of confusion is you develop a guideline to enact with an individual patient in front of you, and then the outcome is not really about that, or it's partly about the patient, and then you have to infer that your act as a clinician will then have some population impact. Clinicians are certainly not taught to think like that, maybe absent of vaccinations, or there's a few other good examples. And I'm just then curious to turn to Deb from the CDC, which is certainly a main part of what you all sort of fundamentally are charged with doing, and how might a clinical guideline framework be different when you're really, I don't know, charged with thinking about true population health, not so much implementing a guideline for populations, but then you're going to implement in one group and the benefit or harm may accrue in entirely some other.
So I think, for us, we looked at some of the original studies that showed, prescription rates were going up for opioids, prescription opioid deaths were going up. Certainly there's been a change recently to where there's a lot more heroin and now illicit opioids from fentanyl overdoses. But then we also looked at studies from like NISDA to where you looked at how many people started with a prescription opioid, misusing it, and then went on to heroin. And so, and I work in an MAT clinic still 1 day a month. And so I talk to my patients all the time, and they talk about how for many of them, it was that initial prescription or getting that prescription for too long that really tipped them over. And so I think for us, it's like, how do you reduce overdose deaths? A lot of that, 10 years ago was due to the overprescribing of prescription opioids. So reducing that should in turn reduce the number of new people getting exposed to opioids and then going on potentially to misuse, addiction, or overdose. So I think taking some of that indirect evidence and trying to weigh that.
Kit?
Thank you. Applaud the work of Dr. Barth for showing us a very practical way of providing guidance. And it kind of strikes me that for the evidence that you've generated and others, like the group in Michigan, that, simply maybe we're overthinking this, and that, for a lot of procedures, 15 to 20 tablets will cover the vast majority of patients. And when we get down to like, what are the risks and what are the benefits and what are the harms? And so, the harms to smaller quantities for a small percentage of people will be uncontrolled pain for some period of time. And if that goes on for a really long period of time and they have no access to care, maybe they start using illicit drugs. But then there's other harms that are more sort of logistical, right? And so, like we would never prescribe patients antibiotics to take for, weeks and weeks without reassessing them. And so in this case, it seems like one of the harms is that they have to call their surgeon back, and one of the things that surgeons don't want to get is phone calls. So how do we assess these sort of more resource utilization harms that may go away with e-prescribing over time, and sort of the logistical hassles with getting a refill, and how do we weigh that against the more clinical and patient-oriented outcomes?
I don't want everybody to go away from here thinking that like a surgeon getting a phone call is a harm. We do this. We get phone calls all the time from patients, and we're constantly, helping patients, to have optimal outcomes. So I think that harm should be like way down there, in your deliberations. I think most of us think that it's a harm for the patient if they live really far away. Like I practice in a pretty rural environment. They have to drive back 2 hours to see me to be evaluated, to me to give them another prescription for opioids. Well, that's a harm for the patient, right? They're wasting a whole day then to come back. But that's where I think e-prescribing is a real big benefit here, because in that small fraction of patients who aren't prescribed enough, you're going to get that phone call. You're going to assess, is there really something bad going on with that patient, or is it just that they just didn't, get enough opioids? And a lot of times you can make that determination over the phone, and then just e-prescribe for those patients. So I don't think you guys should think that that's going to be a terrible harm for the patients. This has been very interesting for me to hear all this intermediate outcome, measured discussion, about in terms of the number of pills used and the looking at the ultimate thing is to decrease the number of people dying of opioid use, dying of opioid overdose. And it's those dotted lines are tough. I can see where you're going with that.
Just to follow up, I mean, do you think the committee should make a recommendation for the minimum amount of time that, if there is regular follow-up, that should be reassessed to see if they need pain? Because oftentimes their opioids are prescribed until the next follow-up visit. So, for a minor procedure, there may be several weeks.
Yeah, I mean, if patients are having surgery, they're all going to get discharge instructions, with a phone number to call. It's my general surgery clinic if they're having, problems, and a lot call. I don't think we have to. I don't know. I don't think we have to do anything different about that. I do think it would be interesting, though, to put a little more onus on the people who are writing the prescriptions to actually follow up with what happens to those excess pills. I think that would be a good idea.
So we have time for one more question from the panel. So, Nick.
Nicholas Karras, University of South Florida again. And sticking with my trend of thinking about developing future evidence, because I love the work showing the reduction in opioid prescribing, but we've talked about how that does or we hope relates to the outcome. So if we're going to generate or make recommendations on how to generate evidence to actually prove that, the first thought that has jumped into my head would be, a larger scale cluster randomized controlled trial to be able to account for the patient variability, but then still have the prospective and randomized nature. And that was my idea. I want to throw that out to you, see your thoughts, and see what other thoughts you had in terms of how to closer link, or in a study, the reduction in opioid prescribing to the outcomes we want to see.
I'm sorry, I haven't honestly really tried to grapple with this too much, so I'm not going to give you a lot of insight on that. But it's a critical question, obviously, and I think I think you guys should think about that. So write some grants, I guess. So it's obviously a really important question.
But somebody said a bit earlier, because I think, that may be one way of addressing it, but somebody said a bit earlier, until you've done the reviews, many of us are familiar with the evidence, but until you've done the reviews, it will be hard, and develop recommendations, it will be hard to design the right study. I think that's really that needs to precede the design of studies, and then our patient care probably needs to influence that to some degree as well. It was an interesting discussion. In Canada, we prescribed opioids. Typically, I prescribe them until the patient see the GP, which is typically very shortly after the discharge from the hospital. So there are ways of thinking about it, and there's probably some evidence in terms of how this can be operationalized.
Great. I think this ends the session 4, and I want to thank the speakers. That was very great. Thanks.